get started, please. First, thank you so much for coming, and thank you to all of you out in the ether for coming. This is a very special occasion for us because we have not only law students here, but medical students and pharmacy students, both here in the room and online, and that just makes this so much more interesting. For me, it's fun too because I get to learn from experts that are coming at this from a different angle, and for all of us, that enrichment is fantastic. So thank you so much for joining us. A word about First Mondays, especially for those who have not been able to come to them. First Mondays was created by the law school in our fourth year of this, and the idea was that there was so much discussion around legal issues that had so much politics dropped in on it, and that people weren't listening to each other through the politics and weren't separating out what was law and what was politics and what were the relationships between them. So this was a program that thought that it would be good to shed more light than heat on the legal problems of the day. And that's what we've tried to do now into our fourth year. There's something I mentioned, one of the things that's unique about this program is we have experts from outside the legal field. The other thing that's fairly unique about this program is we're actually meeting on the first Monday of the month, and half the time we don't do that. And not only that, First Monday was named for the first Monday of October, and we're actually meeting on the first Monday of October, and it's named, well, do you know why it's named for the first Monday in October? What's happening today? Anybody? First opening of the US Supreme Court arguments for the term. And for those of us who at the law school who have long talked about our fantastic Justice Jackson, who we are so proud of, Robert H. Jackson, now we need to talk about the first Justice Jackson, because it's the first day where the new Justice Jackson is sitting on the court. And for all of us in the legal field and legal academia, that's just such a neat day for all kinds of reasons. So thank you for coming to this very special First Monday. It's the second of a series. Dean Willett did the first, and many of you were here, and we learned so much, and we look forward to learning more at this session, and then at the third session, which will either be or not be on the first Monday in November. Let me turn it over to my colleague, Ted Barbieri, to introduce the panel.
Thank you. And so glad to have so many people here in the room, and we have 40 participants over Zoom at the moment, so that'll go up and down too. Welcome everyone.
Say the recording thing.
Yeah, So we are recording the presentations, so just so people know that here in the room and on Zoom, you're being recorded. I'm really excited to welcome our panel of experts here, and thanks so much to Professor Evelyn Tenenbaum for inviting our distinguished guests, and we want to get to them as soon as possible. Barry DeCoster on my right and Kara Alstad are going to present from the Albany College of Pharmacy and Health Sciences. They're going to talk about the unintended ripple effects of the Dobbs decision on clinical and ethical decisions outside of abortion care. Rachel Flink, who's joining us from the Albany Medical College, is going to talk specifically about the effects of the Dobbs decision on people seeking abortion, patients with pregnancy complications, including miscarriage and ectopic pregnancy. Wendy Parker, also from the College of Pharmacy and Health Sciences, will discuss psychological, social, and health consequences of being denied a wanted abortion. So we're really excited to hear these three presentations. We're going to go in order, and then we'll leave some time for discussion subsequent. So welcome to our panelists. We're going to go my right to left, your opposite. And I'm going to hit present. Yeah. So let's see. So does that work? Okay. So we just have to share. So you can see the presentation up above us. We just have to get our since we're in presenter mode.
You had it up there a minute ago. I'm not sure how you got it up there.
Yeah, it's just we have issues then also sharing with our friends on Zoom.
There you go.
Here, let me do. We'll do. If we have it slightly unorthodox like that, is that all right for you? Here, sort of like this. I think it's less than ideal for presenters, but it makes for able to share.
I have some animations in mind, so I'm gonna need it in PowerPoint, but I don't need to.
You-
Oh, yeah.
Okay. You do? Okay.
Just take it out.
Yeah,
Yeah,
so
we don't get the notes.
how did you know to get over better? So it doesn't, so we can present but not. Yeah, sorry, folks. Yeah.
That's right. They're technical people. We're not.
We need to share.
The complications of, sharing between
And then
institutions.
hit.
Exactly.
Yeah, there you.
You don't need the notes.
Thanks so much.
Okay, thank you. How do we look?
So good morning, all. Thank you for inviting us over here. My name is Barry DeCoster. I'm a professor of philosophy and bioethics at ACPHS.
Hello, my name is Kara Olstead. I'm a pharmacist and currently doing postgraduate training through Albany College of Pharmacy and ambulatory care. So I work in rheumatology, nephrology, pain management, and primary medicine.
And since Kara didn't do this, I did it. I'm known for like overly long titles. So we're interested ultimately in this, and here's a quick overview of what we're going to be trying to do today. Our project today. So we're not lawyers. I'm a philosopher, pharmacist. We are interested in how the Dobbs decision is changing clinical care today. So the case study actually is going to form around this one specific drug, methotrexate. Here's a pretty little molecular diagram of the drug. So it's looked at and reminds me of organic chemistry. The things we're going to be doing and not doing today, right? We're not doing an illegal analysis. We are sort of looking at some of the clinical and ethical implications that are happening in the clinic today. So these are things that in the state of New York, we're kind of covered because abortion seems safe enough right now. Some of this is up in the air, but our colleagues across the country are talking about these things in a number of ways. So we're going to raise up just kind of a network of problems that we're seeing. We don't have final answers of it because there's so much up in the air. So with that, Kara's going to give us a quick overview of the drug itself.
Thank you. So to begin, we have methotrexate's how it works. So it works to slow cell proliferation and cell division. So when you think about different autoimmune diseases, that means like calming down the immune system back to its normal baseline. When you think about uses in cancer treatment, it's preventing those rapidly dividing tumor cells from getting bigger and expanding. So it's just kind of resetting things to normal. It's not stopping any functions of the body, just helping it kind of get back to its normal process. And it's something that we've been using since the 80s. It got its FDA approval in 1982, which is really great for us. It means we have years and years of real life data. So when drugs are studied, they're often like very controlled with how patients are using them, or maybe they're excluding patients that weren't able to follow the regimen from their results. So real life data shows us how it works for our patients in real settings. And so that's very valuable for clinicians. Because it has been around for a long time, it is relatively inexpensive, which is great for our patients. And it has many, many uses for treating diseases and even preventing progression of diseases too. It's not perfect, so we do have to talk about the boxed warnings. So these are the things you might think of when you see drug commercials and they say all those scary things and you're like, why would anyone take this? But in the clinics, we do have ways to manage these, and so they're not as scary to us. First is hypersensitivity reaction. So if you have a history of a severe allergic reaction, don't take this again. Next, we have toxicities. I'll let you read those, but basically these are serious concerns, but a lot of them present with higher doses or longer treatments. So they're things that we can manage or monitor in the clinics. And for a lot of patients, they can take this drug without experiencing these side effects here. And then last, we have pregnancy. So there is embryo or fetal harm possible. So if you think of a fetus, it's just a bunch of rapidly dividing cells. So you can see how that relates to the medicine here. So if we have a pregnant patient, they would not want to take this medicine. Here we have all the different indications you can use methotrexate for. So lots of indications. It's a very important drug to us. Number 36 is why we're talking about it today. Because of this indication, it is seen as an abortive therapy, which causes complications for all the other conditions here on the board. And for like the top 8 here, you can see why that would be complicated if we weren't able to get them timely treatment. For a lot of cancers, we want to be able to act fast. Additionally, we have rheumatoid arthritis. So right now I'm in rheumatology. I see a lot of patients on methotrexate. This is like the gold standard of treatment. It's the first treatment we go to. And it is successful at preventing disease progression. So it's a very valuable tool for us to be able to use. And then last, we have the ectopic pregnancy. I'm just going to briefly talk about how it relates to methotrexate, but we'll hear about that a little bit later on. So basically, it's a non-viable pregnancy where the egg is implanted in an inappropriate area, like the fallopian tube. So when not treated, this could cause a lot of severe complications like internal bleeding, which would be harmful to the mother. So methotrexate allows for a non-surgical intervention. So it's a great option. Without it, there's maybe other complications that could occur from other treatments that would be available down the line. But that's not really the focus of what we're talking about today. We're going to look at a different case just to kind of set the tone here. So we have a fictional patient, Joan. We changed the location just because, as Barry stated, New York is a little bit safer right now. So we have Joan, a long-term customer of the pharmacy who's looking for a refill on her methotrexate. She's 46 years old, a widow, and has 2 children in high school, and she has no intention of pregnancy at this time. She has rheumatoid arthritis, but her condition has been well controlled for years because of finding the right regimen, which is methotrexate. But at this time, the pharmacy is unable to refill her medication. So that could be maybe she received, her doctor sent an electronic request to cancel the prescription because now they have fears about using methotrexate. Maybe the pharmacist felt they didn't have appropriate documentation for what the medication was being used for, so they didn't feel comfortable filling it. Or maybe the insurance, because this is seen as an abortive therapy, didn't want to pay for the medication and is requiring further paperwork to be submitted to get it covered. So I'll pass it back to Dr. DeCoster here.
I guess one other thing before I get into my part of the slides I want to point out is just that in bioethics, often a new technology is the interesting sort of poses new problems, right? Genetic engineering and the possibilities there, and then ethics and the law catches up. Here we have an interesting situation. We've had standard of care for years and years, and now the law is the variable that's really switched and thrown a bunch of questions into the mix about clinicians who had standards of practice just months ago. They don't know necessarily what to be doing today. And that's the thing we are interested in. So if we go back to Joan, in the case of Joan here, what's been thrown up in the air, there's at least 2 clinical worries that come to mind first and foremost. The clinical patient relationship has been sort of changed, right? So when you go to the doctor, you ask the doctor what the doctors should be focused on, what is best care for you individually. In this moment, we knew 6 months ago what would have been the best care for Joan. She'd been on this drug regimen for a long time and it was working. Here now we have a new variable that's come into play. The doctor, the clinicians, because it could be pharmacists as well, will be playing a kind of self-protection in this moment. What is best medically is no longer sort of and it could be an option, right? But it puts the licensure of the clinicians at risk. And that's a real worry. We're starting to hear more reports of clinician-clinician relationships being put to the test. So it could be moments where we still know what would be best for Joan. In some places, the doctors may be refusing to write the prescription. In other places, the pharmacists may be the ones choosing not to fill the prescription. So we're having a clinical tension there between the healthcare team. In certain moments in the past, where I'm not sure if it's covered yet in your curriculum, in our curriculum, we talk about conscientious objection is a real option and a number of other ethical sticky kind of moments. Usually that's say around prior abortion care decisions where if the moral worries of the clinician might sort of say, I don't want to provide this service to my patient, you can't abandon the patient, but you can set the patient up with a different clinician who is willing to fill that need. In that moment, it's been, again, a sort of standard ethical approach to any of these kind of worry issues. Here, though, it's going to be state by state complications about who can do things and what it means to transfer a patient maybe out of state, or we're talking about sanctuary cities or sanctuary states at this moment. All the sort of the conscientious objection issues have sort of been become even messier, more complicated. And ultimately, there's a negative impact on clinical judgment. We're hiring these people because they're very smart and they went to school for a very long time to tell us how to stay safe, how to stay healthy, right? And now we're sort of taking what was, again, standard of care out of the little quiver of possibilities of treatment and saying that clinical judgment has been overridden. Also for a different purpose here, right? Nobody was writing the Dobbs decision, I think, worried about rheumatoid arthritis. 2 other clinical impacts here that are important to note. One is it's still unclear what's going to happen with insurance issues. So if methotrexate is off limits, then what's going to have to happen is doctors and pharmacists will be providing a less effective, typically more expensive medication in order to treat the same disorder. And methotrexate was one of those good ones in one sense, it's prevented the progression of the disease of rheumatoid arthritis. If they're going to rely on methotrexate, a number of insurance agencies may be doing the sort of protective move of asking for why this needs to be the drug, why can't we go to the other ones? And that will always require more paperwork and more time. So again, the patient will be sort of delayed in what is possible for the treatment there, or they're going to have to pay out of pocket themselves. The other thing that we've been playing around with, and I honestly don't know where I stand on this, the doctrine of double effect has been sort of a clinical standard for a long time, especially around end of life issues, where you can treat pain, but the treatment of pain may hasten death. So if you think about the example of morphine as a sort of powerful pain preventive at the end of care, what happens is it lowers respiration. Bioethics and clinical norms have said, if you're treating the pain, you are not ethically responsible for killing the person, right? The Catholic Church, which is a rather conservative institution, is behind the doctrine of double effect. You are treating pain. If something else happens afterwards, the idea is you're not killing the person. You are instead treating the pain, and sort of the hastened death has happened on itself. There might be ways of sort of thinking through how the doctrine of double effect can be modified to handle like a case like Jones. If it's an ectopic pregnancy, you may be trying to prevent the damage to the woman. There's no sort of viable way to save that fetus, no matter what certain politicians are telling you. Their science is wrong. Like, you can't save that fetus at the moment. It gets really complicated, though, for me to think through what is the doctrine of double effect if treating rheumatoid arthritis, right? Jane's case itself. I don't know if we have a way of sort of easily talking about treating the rheumatoid arthritis, but worrying about the fetus there. I think the burden will be instead put on her to use a number of birth control situations, and we all know none of those will be perfect. So as we're ending here, moving on to our next topics, I just want to sort of give us a quick summary of what we're worried about here, right? Healthcare for women who will change. It's going to allow a number of women to get really, really sick before they get what was standard of care prior. Because of the Dobbs decision, a number of safe, legal, cheap, and effective medications, and I want to underline that word effective, will now be off limits. Some will not be prescribed, some will not be filled. There's a whole set of ethical and clinical standards and norms that have just been upended. And I think we're just starting to see the beginning of them, right? So that mapping of what will be the impact of this is going to change, and it's going to keep updating for a number of times. And then the one that just, I think, has really got me thinking about this and why I'm in front of you today, right? It's going to be the most vulnerable who will be paying the impact on this, right? It's going to be women. It's going to be women of color, probably a theme that you're going to hear for the next 45 minutes. But that it's not like I, as a philosopher, will pay for this, or clinicians will, right? Ultimately, it's going to change the way patients themselves are cared for. So with that, thank you.
Mine. Karen, I may need you to help me. I can't find the window to pull up the,
So through Zoom,
yeah.
and then
Now I go back to the PowerPoint.
yeah, it should be all set
Thank
there.
you. I'm an old millennial, so I struggle with technology. Thank you for having me today. So I'm going to start out talking about the risks of pregnancy. Pregnancy creates a significant stress on the body, even under the best of circumstances. The blood volume increases, which causes stress on the heart and kidneys. Breathing becomes more shallow and rapid. Intestines slow down, which causes nausea and constipation and reflux. At term, the uterus is receiving 600 milliliters of blood per minute, which means that bleeding after delivery can be catastrophic. That's all gone within 6 minutes. And there's an increase in clotting factors that happens with pregnancy, but that can cause dangerous blood clots during and after pregnancy as well. These stresses cause universal discomfort, as anyone who's been pregnant can attest, but they also cause significant dangers for both healthy patients and especially patients with underlying health conditions. At their worst, these health risks can lead to maternal death, which happens to about 700 women in the US each year. Mortality has risen in recent years, and the US now has the highest maternal mortality of any developed country. And then the risk is also not evenly spaced, as Barry alluded to. It's more common in certain areas of the country and among certain racial groups, especially Black and Indigenous populations. So how long does pregnancy need to last for? Decisions about delivery timing rely on balancing risk to the patient, the pregnant person, and the fetus. This is a schematic. There's no units on this chart, but because of the health risks of pregnancy, it's always safer for someone to not be pregnant. Health risks increase as the pregnancy progresses. And then on the other hand, the neonatal risks of prematurity decline as the pregnancy progresses. So in general, it's always safer for the fetus if the pregnancy continues longer. The decision to prolong pregnancy and increase maternal risk is balanced against the benefit for the fetus. And in a pregnancy without serious complications, the lowest perinatal risks are between 39 and 40 weeks. And I don't know if anybody who's not been pregnant before has encountered this, but you're basically not allowed to electively induce delivery until 39 weeks. So you were staying pregnant that whole time. The risk of pregnancy, though, can vary significantly. So on the perinatal side, fetal anomalies or placental insufficiency could mean that viability or the ability to survive after birth comes later than usual. And then with lethal anomalies like anencephaly, where the parts of the brain don't form, viability never comes, and the timing of delivery is irrelevant for long-term outcomes. So that's that line that just goes straight across the top. It's never dropping down from an absolute 100% risk. On the maternal side, underlying health conditions or the development of pregnancy complications can cause the lines to slope up a lot quicker than usual, and ending the pregnancy may be necessary to save the pregnant person's life, regardless of the potential for survival for the fetus. These lines are also affected by risk tolerance and priorities. Someone with fewer resources may have less ability to tolerate significant medical needs or prolonged hospitalization than someone with more support. Someone who desperately wants a child may be willing to accept more personal danger than that same person or someone else who becomes pregnant under less desired circumstances. So the principle that matters here is shared decision-making, which Dr. DeCoster also kind of alluded to. But I, as the physician, bring my medical knowledge and professional experience, and the patient brings their personal values, their priorities, and their experiences, and together we figure out a plan that works for them. Which brings us to the concept of abortion. So when a pregnancy is interrupted in circumstances where there's no potential for fetal survival, that's considered an induced abortion. There's about 900,000 abortions each year in the US. 1 in 4 women will have an abortion by the age of 45. Abortions are more likely to be needed by demographic groups that are at higher risk of unintended pregnancy, including poor women and minority populations. About almost 90% of abortions occur in the first trimester, and almost 2/3 occur before 9 weeks. Patients seeking second trimester abortion care, which are sort of the ones that you hear about more dramatically, are more likely to have later recognition of pregnancy, difficulty making their decision, and conflict with a male partner. About 1% of abortions take place at 21 weeks or greater, and those patients are more likely to have faced challenges accessing abortion care. And then also fetal anatomic abnormalities are usually not detected until about 18 to 22 weeks. So those patients are more likely to have fetal anomalies, as well as stresses on the body increasing as pregnancy progressing. So maternal health risks might not become apparent until later in pregnancy. In comparing the maternal health effects of abortion to the spontaneous end of a pregnancy, as I said, it's safer to end a pregnancy than continue it. It's always safer to not be pregnant. So in the first trimester, surgical abortion has significantly lower mortality than miscarriage. And surgical abortion in the second trimester has lower mortality than a full-term delivery. Overall, US maternal mortality from childbirth is 14 times higher than from induced abortion, legal induced abortion. So this gets us to the current situation. This map took me, I had to redo it like a ton of times just in the last month, and like changing colors and talking to colleagues in other states. So the Dobbs decision allowed states to ban abortion outright. This map doesn't say anything about actual accessibility to care. Still, a lot of these states have restrictions on care settings, on payment, other obstacles that makes care practically inaccessible, even if it's legally permitted. Some of these bans have no exceptions at all, not even for maternal life endangerment, which of course means that both the patient and the fetus would not survive. But most have theoretical exemptions for imminent threats to maternal life. However, the statutes are written very vaguely and often require an affirmative defense. If there's any other non-lawyers in the room, that means that instead of having an indication for abortion that's excused from the law applies to all cases, and physicians have to later justify their actions after they're already being investigated for performing an illegal abortion. The fact is, pregnancy-capable people have the same right to bodily autonomy as anybody else, and these laws are part of an overarching assault on equality and freedom. But in making these laws so extreme and absolute, lawmakers in many states are preventing clinicians from following the standards of care for medical practice. So I'd now like to discuss a few recent patients that we've taken care of here who needed life-saving abortions and whose ability to access them is now dependent on where they live. So we recently had a patient at 15 weeks with a new diagnosis of an aggressive cancer. Her oncologist felt that rapid induction of chemotherapy was necessary to prevent disease progression and save her life. Her pregnant state put her at a higher risk of complications from both the cancer and chemotherapy, and the most effective drug regimen would not allow fetal survival. This patient may not have been imminently dying, but continuing her pregnancy and delaying cancer treatment would have allowed her disease to progress and likely led to her early death, instead of giving her a chance to survive and see her existing child grow up. She would not have been able to access abortion care in 16 states. We had another patient whose anatomy scan at 21 weeks had shown skeletal abnormalities, and after follow-up testing, it was confirmed to be a lethal skeletal dysplasia. If she went to term and delivered, her baby's chest would have been too small to allow proper lung development, and her baby would have suffocated and died shortly after birth. What's more, because of the asymmetric growth, a delivery at term would have required a C-section, which has higher risk of complications and a more difficult recovery. 27 states would have required my patient to continue the pregnancy to term, risking her health and disrupting her family's life for a fetus that could never survive. I did not personally care for Chrissy Teigen, but I have had many patients like her, and this is in my head over the last couple weeks. So she spoke last year about losing her pregnancy due to a placental abruption, which is when the placenta peels away from the wall of the uterus, leading to ongoing and potentially heavy bleeding that's life-threatening to both the patient and the fetus. At the time, she called her experience a miscarriage, but many of us kind of read between the lines and suspected that she was actually diagnosed with an inevitable abortion, which is a pregnancy that's currently alive, but in the process of a spontaneous abortion with no chance of survival. She recently came out just in the last week or two with the fact that her pregnancy had not already demised at the time of the intervention, and her personal realization that the induction to save her life was in fact an abortion. In 17 states, her doctors would have needed to delay care and prolong bleeding to confer with hospital attorneys before intervening, and then would be potentially left to fear an eventual lawsuit or criminal charges for their role in saving her life. The final patient I'll discuss is one whose complexity highlights the absurdity of trying to legislate medicine. She presented with a heterotopic pregnancy, meaning there was twin pregnancy, there was a pregnancy implanted correctly in the uterus, and another pregnancy that was ectopic or outside the uterus. Ectopic pregnancies are usually in the fallopian tube and can be treated with medication, methotrexate, which would also harm an intrauterine pregnancy, or the tube can be surgically removed, and that doesn't cause a lot of risk to the intrauterine pregnancy. Though some. But in this case, the second pregnancy was implanted in the interstitial portion or the opening of the fallopian tube where it connects to the uterus. This is a rare site, and it's especially dangerous due to the large blood vessels in that area that can cause catastrophic bleeding if the pregnancy were to grow and cause the uterus to rupture. This would not only put the patient's life at risk, but would also definitely lead to the loss of the other pregnancy in her uterus. So in this case, direct interruption of one pregnancy was necessary to save not only the patient's life, but also her other pregnancy. In 15 states, the ability to perform this procedure would be very limited or impossible. So this is just a snapshot of the many patients whose access to safe care is compromised by the Supreme Court's revocation of protected abortion access. Because abortion is safer than childbirth, denying access is projected to automatically lead to a 24% increase in maternal mortality, which is especially shouldered by Black women who already experience significantly higher maternal mortality. This analysis doesn't take into account the many patients terminating pregnancies for maternal health reasons, and thus the actual numbers could be higher, especially for people who don't have the resources to travel out of state. And it seems like this is already happening. So after Texas banned abortion in 2021, researchers reported higher rates of maternal morbidity for patients presenting with pregnancy complications, such as pre-viable rupture of membranes, who were not able to receive care in Texas until they had become infected or unstable and their life was imminently in danger. Additionally, last month, Texas announced that they were delaying release of maternal mortality data, which most people are assuming is because more women are dying now that abortion is banned. In addition to patient health, these bans are leading to doctors not wanting to practice in those states. Because abortion is the standard of care in many obstetric situations, some of which I just went over, even those OBGYNs who don't routinely provide abortion care still would fear the consequences of practicing medicine in a place with legislative intrusion into their medical decision-making, having to risk the choice between medical malpractice versus criminalization. It's also affecting trainees, with medical students not wanting to train in places where they can't learn these comprehensive OBGYN skills, which include abortion. And this has long-term workforce effects because many doctors end up practicing where they train. So the end result is that these workforce issues will exacerbate the existing OBGYN shortage, especially in certain geographic areas, which will create further barriers to already vulnerable patients being able to access quality healthcare. Thank you. Zoom, yeah.
Okay. Maybe. There we go. Good. All right. Hello, everybody. I'm Wendy Parker. I am faculty over at Albany College of Pharmacy and Health Sciences. I run a public health program, and so, but I'm a sociologist by training. So today my talk is going to be a little bit about public health and the impacts there and sort of the social aspects that go along with the Dobbs decision. So with that, so because not all of you spend lots of time talking about public health like I do, I thought this is a little helpful to sort of think about the context, right? So in public health, while we care about the individual clinician relationship as well, we tend to focus much more on the community level concerns. And so the sort of language public health uses is saving lives by the millions. The idea is that in this case, well, we're pursuing equity, reducing disparities. Those are the key kind of public health goals here. And they go back to tying to both of the topics that we've talked about so far as sort of bodily autonomy, right? So starting from that as a premise as well. So just to give you some context of who's actually getting an abortion at this point, this is 2016 data, so not perfect, but the vast majority of people who are having an abortion in this time frame already have a child. But what should be most noticeable on this slide, I hope, is that 75% of them are poor or low income. And that is what public health is most concerned about, I think, in this equation. The other thing that I think is notable, because I think we have a sort of public sense that teenagers are getting a lot of abortions, and that's actually not true. Only about 12% of abortions in the US are teenagers. And they're typically 18 and 19 year olds. Only 4% are actually minors. Most of them are in their 20s. Abortion patients are disproportionately poor and low income. So just another way of sort of looking at this is to think about the federal poverty line of being about $18,000 for a family of 3, something like that, in 2016. So we're saying that about half of the people are getting that are having abortions are below that poverty line. So if you think about what that might lead to as we sort of move ahead in terms of talking about the consequences that Rachel was just outlining, right? The ability to get access to resources for pregnancies and for abortions is limited for this population. So the other sort of way to think about this, I'm just going to move the little Zoom window so I can read. we think about unintended pregnancies or unplanned pregnancies. And while they've declined over the last 20 years for all women, it's not at equal rates. So nearly half of all pregnancies in the US today are still considered unplanned or unintended, which that language is used by a lot of people and essentially just means that you weren't trying to get pregnant actively. Does not mean that you weren't using birth control. It doesn't mean anything else besides that, right? But if you look at the specific, excuse me, the specific statistic that I have there below is the unintended pregnancy rate among women in below the federal poverty level is 5 times more than that with people who are what we would consider middle class, right, at 200% of the poverty rate. So again, what we're talking about is that this is not equally distributed, right? So why does this group of people typically get an abortion? So there's lots of different reasons. This is just a sort of summary list, right? So lack of resources for or insurance for adequate birth control. So some of this starts long before they're pregnant, right? So lack of primary care, lack of connections to an OBGYN services, lack of affordability of birth control. So that combines to the second one, lack of access to just appropriate healthcare in general. Complex relationships that impact birth control usage, right? So birth control disproportionately is a woman's healthcare issue, right? And relationships specifically in the population that are getting abortions may include intimate partner violence and other things that may not allow for a woman to feel control over her own body in some of these cases, right? It's geographically varied, access to family planning services. So the map that Rachel showed is, you can find maps like that for lots of different things that show similar patterns, right? Where the Northeast, there's more options. Everywhere else, there's less, is the sort of broad way to think about it. But I want to go back to some of the data that I just showed you, which is that most people who have an abortion already have a child. And so they're saying they can't afford this new pregnancy, or they recognize that another child at this point will stop their ability to go to work, to go to school, and to care for their other children. So it isn't typically first-time pregnancies, which I think is sort of another public kind of cultural misnomer a little bit. So public health and reproductive rights. So why does public health sort of get involved here? Public health seeks the autonomy of women and those who become pregnant to control their body. For public health, this includes access to abortion, contraceptive, and broadly construed reproductive health services, allowing women to decide if, when, and how they will have children. That's straight out of the APHA, which is the American Public Health Association's sort of answer to reproductive justice terminology. But public health also notes that abortion restrictions disproportionately harm poor women and women of color, and thus is increasing our health inequities. Women today having abortions are more likely to be poor. The increased policing of abortion will have continued and expanded impacts on those already struggling to access care. So in this example, and I think shown well by some of Rachel's data as well, as the maternal mortality rate is much, much higher for women of color and poor women. The addition of another child into the mix for some of those women is really going to disrupt not only their life and have consequences for them, but also for their family members, their other children, potentially stop them from continuing work or education opportunities, right? So there's lots of consequences outside of the healthcare realm that public health likes to think about as well. So consequences in general, people seeking abortion healthcare are struggling to travel and may not be able to. This is what we're predicting, I guess. We're speculating what some consequences may be of the Dobbs decision. Travel may be particularly dangerous for undocumented immigrants, for poor women or women in abusive relationships. And as again, shown by the maps that we've seen, some people may have to travel very long distances. And interestingly, there's a lot of data actually from the Texas ban that shows some of those consequences. Even if the state hasn't published the data, there are others who are looking at that data and saying, there's huge consequences in that the way that ban was set up was you had to have multiple counseling visits. And so it meant traveling not just to the state for the procedure, but traveling for multiple days of a week, like usually up to 5 to 6 days Most people was the average stay in the state. And things that might make that easier for particularly undocumented immigrants or poor women or women in abusive relationships, like medication, abortions that could be offered via telemedicine, so eliminating the travel, were also eliminated in that ban. So again, increased healthcare costs are outcomes for all of this. The other place where we're gathering sort of our speculative data around what's going to happen is a study called the Turnaway Study. This was a study out of UCSF, so the University of California, San Francisco, of 1,000 women in 21 different states who had unwanted pregnancies. And what they found was that there was harm, in their words, harm to women being denied an abortion. And they categorized that in these 4 different sort of categories. I'm going to outline a couple of examples in each just to give you a sense. They're mostly self-explanatory, probably. But overall, women who were turned away, so that's hence the name, the Turnaway Study. So not like DeCoster's long titles. They're going for very straightforward. I try. So women who were turned away and went on to give birth experienced an increase in household poverty that lasted for at least 4 years relative to those who received an abortion. Years after that abortion denial, women were more likely to not have enough money to cover basic living expenses, including food, housing, transportation. Being denied an abortion lowered a woman's credit score, increased the amount of debt, and increased the number of negative public financial records, such as bankruptcies and evictions. So this cycle of poverty isn't just short-term, I think is the long-term, it is the longer-term consequences of this that we're talking about. So the second bullet up there says violent partnerships and single parenthood. So physical violence from the man involved in the pregnancy decreased for women who received abortions, but not for the women who were denied abortions. By 5 years out, women denied abortions were more likely to be raising children alone without family members or any partners compared to women who received their abortion. So again, long-term consequences, looking at a five years out from being turned away from an abortion, you now have single parenthood and less resources. Single moms notoriously are the most poor amongst our population in the country. So moving a little bit from the moms to the kids, thinking about financial well-being and child development, the children that women already have at the time they seek the abortion, because we know that most of them already have children, show worse child development when their mother is denied an abortion compared to the children of those who receive one. Children born as a result of the abortion denial are more likely to live below the poverty line. It's also associated with poor maternal bonding, often because of the emotional consequences for women of feeling trapped or resenting the child that was born after the abortion denial compared to those who are choosing their pregnancies. And then the last is women who were denied an abortion, gave birth, reported more life-threatening complications like eclampsia and postpartum hemorrhage compared to those who received wanted abortions. Women who denied an abortion and gave birth instead reported a number of complications for themselves as well as during their pregnancies. The higher risks of childbirth were tragically demonstrated by some women who were denied an abortion and died following delivery. Some of those have made the national news. Yet we know that abortions today, as Rachel also stated, are extremely safe. So what do we do now, essentially, is the question that public health often tries to ask. So our focus will be sort of on safety going forward. I think we're no longer in an era of the 70s, but it's unknown what abortions will look like today going forward. Criminalization of abortion will disproportionately impact poor women and women of color. We know that medical abortions are extremely safe, but it's unclear what will happen to non-medical abortions going forward. So suggestions from a public health perspective of what to do: share information. So accurate, important information and combat disinformation. So that's graphic that I showed you at the beginning from the Guttmacher Institute about who's actually getting an abortion, I think is really important. I think that is not what people think, and that is not what policy level people believe, right? Focus on state level policies and improve telemedicine access to abortion providers. Again, looking at the states to sort of help us regain some autonomy. improve equitable access to contraceptive care, and make birth control more affordable and accessible to all. Again, premises of public health in general. Also thinking about sort of what questions remain for us, right? Resources, money, and policy will now be focused on the criminalization of abortions rather than on helping women have safer pregnancies and birth. So from a public health perspective, that's the wrong use of resources, right? We would rather see those resources focusing on getting the woman out of an abusive relationship, working to get her adequate healthcare and birth control access, and then focusing on the children and how her other children are faring in the system today, right? So what will be the resources going forward for unplanned pregnancies? We know, again, that about 50% of all pregnancies today are unplanned. So what are those resources? Where will women go to seek help in conversations that they used to have with their providers, maybe, that, as you know, we pointed out, might feel uncomfortable, or the clinical relationship may have changed as a result? And then are the other systems ready for the consequences of all of this, right? So there may be more adoptions, more children in foster care. Where are our resources going? If our resources are going to focus on abortion and criminalization of those women and those providers, why not instead maybe spend those resources on adequate healthcare, access to birth control, childcare for people so they feel more comfortable having the pregnancy and taking it to term?